to work on a case study, but we're going to talk about everything about shock first, and then go from there. All right, so some first things is names of shock. So if you're doing questions and you're doing questions from different resources, you're going to see these names being thrown around, like dissociative, obstructive, cardiogenic, distributive, right? So that's just another term, all right? They're a little bit out of flavor because of, you know, they're just calling it what it is now, right? So septic shock, or, you know, cardiac tamponade. So when you're looking at these things, like, they'll call it neurogenic shock, right? So they're not going to call it distributive. It becomes a little bit gray because at one time we used to call it that, right? So you see a lot of these kind of words in questions and different things like that, and they're basically older words, right? So it's kind of when we're talking about when we used to call heart failure systolic or diastolic heart failure, right? Where, you know, medicine's changed a lot as far as like pulling the patient in, and that they can understand what's going on and not speak so much doctor talk and different things. And that's kind of where that change happened. However, if you're doing questions and different things like that, you're going to see these different terms on those questions. So like when you look at dissociative, right? So, you know, anemia, hypothyroid. So it basically means outside, right? So whatever the system is, it's something outside that is interfering with it. Obstructive is exactly what it sounds like. And if you think about like tamponade, you have your, you know, your four chambers, and you have the pericardium, and tamponade is fluid in the pericardium, right? So, and we said that that's why you get those muffled heart sounds and different things. That's an obstruction. So obstructive shock, right? So that would make sense. And the same thing when you think about like a pneumothorax. Now, a pneumothorax is obstructive, and that makes sense as well, because of if you have your lungs here, and then you have your chest, and then you have ear, like in a pneumo, right? So you get some collapsed here. So that's why we put a chest tube in, and that's obstructive, right? A PE is just basically on the vessel, right? So the PE is an obstructive shock. Well, over the time, we've just kind of said, well, that's not what we're going to call it anymore, and we're just going to call it what it is. However, like I said, things that you see, different things like that, are going to see what you're going to see those terms. Cardiogenic shock, it's exactly what it is. The heart is not pumping. Distributive, neurogenic, and hemorrhagic. Dehydration, hypovolemia. All right, so I just kind of pulled that up. That's not my thing anymore, because we don't, like I said, we don't use it as much anymore. You just see it in questions. So if you're seeing that, that's probably what you're seeing. All right, so some stages of shock too. Now we started talking about laying down the foundation last week, and what happens is that now you start to do questions. So now you're going to see different things. You're going to see compensatory is also called non-progressive. Progressive is also called decompensated. Refractory is also called irreversible. All right. So once again, we have medicine in the way that it's teaching and explaining itself to the general public. And so a lot of times what happens is these words get pulled out and they start talking about it in a different way. However, questions are what they are. So some of the books that you're using, and generally, 2010, 2008, 2012, because a year goes by very quickly, right? So, and then you don't really see that date on that book, because that's why Iggy's book, is 6 years behind the time. By the time Iggy's edition comes out, it's already been outdated. That's kind of how it works. It's just things change so quickly. However, those questions and books and different things like that become very vague. And so what happens is that if you're doing a Saunders question, or you're doing a Davis or whatever, and they're talking about non-progressive, you just have to say, okay, well, non-progressive is compensatory. Right? And it means exactly what it means. It's non-progressive, which means that it's not progressing to the next stage, right? The body is compensating. It's kind of early shock, right? So Early on, and so what we used to call it was not the onset. Yeah, I think it was the onset. And then they moved away from that because they said, okay, let's just go to 3 different phases. Now, what do I think NCLEX will do is they'll just tell you they're in shock. They're not going to say, put you in that situation. However, refractory irreversible is exactly what it is. It always kind of stays there. That's the stage when we talked about septic shock. That patient, suddenly the brain is being perfused and the skin is no longer being perfused. That's the irreversible stage, which is a big issue because at that stage, we're in higher Maslow, right? So which means that, you're calling a family in and trying to get things kind of moving. So early shock, we identify the underlying cause, fluid resuscitation. So we talked about that with septic shock, all the fluid that we give. We might give norepinephrine based on the sepsis bundle, right? Severe shock, treat the pathology if it's hypovolemia, acidosis, CRT, hypocalcemia. Vasopressins, epinephrine, mergemol. All right, so this is just a infographic that just kind of goes through this basically thing. You see down here methylene blue. All right, now don't need to know that. That's nuts to know. That's a big debate that they're talking about as far as treatment for refractory. And that's the problem with sepsis and septic shock is that over the years, there's sepsis conventions, there's sepsis committees and all that stuff because it's the #1 killer, right? So once a patient goes septic, that's pretty acute and that patient's in the ICU. So they come out with these different protocols and different things over and over again that they suddenly start to say, well, does this work? Does this not work? And for this one right here, they're talking about methylene blue, right? But there's a lot of contraindications about methylene blue. So until they can figure it out, it becomes gray. Will you be tested on it? No, you're not going to be tested on that. When you're looking at shock, you're looking at, do you understand what's going on with the patient in relationship to the medications and the hemodynamics? And we'll talk about that. So we're going to pull this together with a case study, and you should write down this graph. Okay, so this graph will basically be the hemodynamics, and that's what we need to know because that's basically pulling in, this to the heart, to the brain, and then to the fingers and toes. And how this basically works is this is volume, right? So volume is key with shock, right? So either have too much volume or too little volume, right? And that's the big key when you start to figure out it. And then you either have too much volume because of the heart's not pumping, which is cardiogenic, or too little volume because the SVR is not squeezing, right? So, or too little volume because you have a hole, right, and you're losing blood, or you're losing volume. You're the P's, right? Peeing, puking, pooping, right? So diuretics, all those type of things. But generally, is that everything should be working here. Right. So let's go over this. This is the vasculature. This is the heart, the pump. This is the SVR, systemic vascular resistance. And we said that systemic vascular resistance is another word of just alpha. And it's the squeeze out here in the vasculature. Right? Because in relationship to a low volume, the vessels will start to squeeze. That's a normal thing. So SVR is squeezing. So increase SVR should be happening. However, we talked about with septic shock, the problem is in the SVR. All right. Why does that work? Because the brain needs a mean arterial pressure of 70-75, and the skin, that we have even distributed shock, right? So distributive shock is this distribution that's going on, right? So let's work on this sheet. So you should work on the sheet, and as we move through it, let's go into it. So the first thing we're going to talk about is going to be anaphylaxis, right? So anaphylaxis is an acute situation right now. We don't worry too much about the hemodynamics with that because that's now. That's deal with it now, right? Deal with the problem, right? So if somebody has anaphylaxis, you're not going to be like, oh, let's hook up a swan, let's figure out where they're at and everything like that. No, you're not managing it. You're dealing with it. So anaphylaxis is acute airway always. All right, so the next thing is pump failure. Well, when you're talking about heart, the problem is here, right? The problem is the pump. It's not working. All right, so that concept, drawing this person, kind of shows you, okay, well, here's the problem. So if this isn't pumping right here, that means that this fluid, the volume, will start to go up. All right, so that's our first thing. So our volume goes up. And, you know, why does it go up? Well, because the blood's not pumping, the heart's not pumping. So that's a big deal. So what we're looking at is, so if the heart isn't pumping, the blood pressure, right, isn't going up, right? So, and the reason it's not going up is because you have no pump. You have no pressure that is actually pumping. All right, so cardiac output. So if your heart isn't pumping, you have no cardiac output, right? That's just basically what it means. Because in order to, what is cardiac output? Well, we said that cardiac output, CO, right, half of that is 4, right? 4 to 8 liters per minute, right? So think about that. The heart is pumping 4 to 8 liters per minute. So if it's pumping 4 to 8 liters per minute, you need a pump. And if you're in cardiogenic shock, you're not pumping, right? Also, cardiac tamponade, you're not pumping. So that's why they go into cardiogenic shock. CHF, or a post-MI, right? Post-MI, risk of CHF or cardiogenic shock. Why? The MI has caused damage to that ventricle, and therefore the patient isn't pumping, right? Decreased cardiac output, right? So that's decreased. All right, well, what about the heart? Well, the brain, because suddenly the brain's not getting perfused, so the brain is going to say, what's going on over here? So it's going to talk to the heart, and it's going to actually increase that heart rate. Because the SA note is indicative of specifically what's going on in the brain's response to whatever this is. So if the person had a low volume, the heart rate's going to start to increase, and that's a normal mechanism. So heart rate increases. All right, so now when you think about stroke volume, you think about stroke volume, right? It's volume related, and that stroke volume, there's not enough volume. So you think about the greater the fill, the greater the pump, and when we're talking about that, you don't really have the volume there to be pumping, so that will be decreased. Now that's nuts to know. You don't need to know. That's the same thing with like pulse pressure. I used to have this sheet with pulse pressure on it and stuff like that, but it's just neuro pulse pressure widen. That's all you need to know. SVR, so if we understand this isn't working, the natural mechanism of the SVR will start to increase. All right, so now if the cardiogenic shock isn't pumping, right, so the ejection fraction, so if you don't have a good pump, it's not going to be able to pump the ejection fraction. The fraction of blood coming out of the heart isn't going to be enough because it's going to be decreased. And the reason it's decreased is because it's not pumping. So that will be decreased. Well, you're going to start to see hypoperfusion. And so that means this person is going to be cold and clammy, right? So diaphoretic, cool and clammy, shock. JVD, well, it's volume. They're not pumping, so they start to fill up. And CVP, they start to fill up. And then wedge pressure, they start to fill up. Okay, so meds. What do we use? Okay, well, do you think we need beta, alpha, or alpha and beta? Right, so we would just need beta for this patient, right? Because it's a pump problem. We don't want this problem over here, so we'll use dobutamine for those patients right there. And we might use something that's going to vasodilate, which somebody brought up earlier. And this is a constrictor neo, right? That will increase SVR. These will decrease SVR out here. So if I have all this volume and this is all the SVR squeezing, you know, if it's squeezing, then what's going to happen is we don't want it to squeeze. So we're going to vasodilate and let them relax. All right, so the next one is volume, so low volume. And when we're looking at low volume, it's exactly what it means, right? So it's low volume in the vessels, right? So peeing, puking, or pooping, diuretics, we talked about that on Pavilion. Bumex, right? So Bumex causes low volume issues up there. That's why they go into acute renal failure. All right, so we have the same makeup here. Right, so with the heart there, then we have the vasculature. All right, so it's volume related. So the heart is okay, and the brain, and then the fingers, right? So fingers and toes. All right, so let's go. So it is low volume. All right, so blood pressure will be low. Cardiac output. All right, well, that's a little bit interesting because, you know, if it's low volume, you have low cardiac output. Now, it's a little strange because sometimes that cardiac output, it depends on how low it is. Right? So the heart rate starts increasing, okay, to a fact that the heart rate will go up. So this is a weird sort of thing with cardiac output. So the brain doesn't get perfused, so it relates to the cardiac output. And then what happens is that the brain says, okay, we'll speed up. Well, cardiac output, right, is CO, right, that to 4 to 8 liters per minute. So can it pump 4 to 8 liters per minute? Well, yeah, it could, right? Because if it's a volume problem, if the heart rate's going fast enough, it's going to be able to meet the demand, and that's why the heart rate goes up. So initially we might see it up, then we see it down. So that number tends to be a little bit all over the place. It all depends on when you're talking about it, right? What kind of volume deficiency you have, whether it's blood trauma, hemorrhage, dehydration, all those type of factors, and how far along we are. So if you see a variable rate on that, that's why, right? Because it all depends on, okay, it's kind of like how, you know, like computers and different things like that, right? So I always think of like computers and phones and different things that when you, like a river, right? So if you jump into a river, you know, you're in the river right now, but then the river just keeps on going, right? So the point is that it's all in the matter of we're looking at it from this direction right now, okay? Hypovolemic shock. So if that hypovolemic shock is something else, the river keeps on going. So the problem is that you never really know where you are when you're looking at cardiac output, unless you really understand hemodynamics and you're monitoring that patient. So stroke volume, less volume, SVR will naturally be increased in response to that. So ejection fraction is also another thing of what we were talking about, right? So cardiac output, heart rate goes up, and therefore the amount that it's perfusing out increases. But once again, depends on what kind of hypovolemic shock we're talking about. Skin, cool and clammy, JVD will be low, and CVP will be low, and wedge pressure as well. So quickly on JVD and CVP, you know, you have CVP, which is JVP, right? So see the volume peripherally, right? So see the volume out here. And I always say that it's peripheral volume. Also, right atrial pressures. Right? So what that means is that, you know, if you have somebody who's +3 edema, they have a high CVP. Okay, so that's kind of what it is. Right? If they have tenting, they have a low CVP. Right? And then wedge pressure is left atrial pressure. Right? So it's over here, and it's towards the lungs. And because it's towards the lungs, that makes it more acute. All right. And then meds. Okay, so let's talk about the meds. All right, so dobutamine makes no sense, right? Because we don't have to keep on pumping the heart. You have a low volume. So treatment would be volume, correct the underlying cause, and that would be it, right? So you correct the underlying cause, and whether it's blood or fluids or that stuff. So we talked about different kinds of fluids and why we need to know that. So, all right, so that's that. So that's low volume hypovolemic shock. All right, so the next thing is we're going to talk about is septic shock, right? So septic shock is hemodynamics, right? So and we'll do that in the case study today. All right, so septic shock, right? So let's draw a little man again. And so we have volume, then we have the heart, and then we have this, and then we have the brain, and we have the fingers and toes. All right, so same thing. All right, so let's talk. Where's the problem, right? The problem is here in the SVR. And we're not going to go too far into that. You know, so the SVR is vasodilated. Right? So vasodilated causes a hypovolemic state, which brings up, you know, why we have compensatory mechanisms. Compensatory mechanism, when you're looking at this sheet, is it a volume relationship? Yes. We're always looking at volume with septic shock patients. Why? Because they're vasodilated out here. And if they're vasodilated out here and we're giving them volume, we're giving them pressors and all that type of stuff, we are always managing volume status. It's a low volume status, you know, unless the patient starts to, you know, goes into acute kidney injury or acute renal failure. And at that stage, that patient is in a hypervolemic state. So the initial state is low, right? So, so blood pressure will be, so it's a low volume state, so septic. Blood pressure definitely be in the toilet, right? So BP, right, be low. Mean arterial pressure, right? We said the brain needs 70, 75, but the fingers and toes, like the kidneys, need 60, 65. And that's why we're always trying to prevent that from happening. We see it mentation changes and stuff like that. And then cardiac output. Well, the response to this is to increase heart rate once again, increase cardiac output. So it's all relationship to where you are on this spectrum. Stroke volume, same thing. Heart rate's up and no, down, and then SVR. SVR is going to be down, right? So that's why, you know, because it's an alpha problem. Ejection fraction, the same thing as the other one, but depends on the state, where we are, right? So we'll say low for now. They're going to be hot, right? And that's the principle, right? So they're always warm. Think of fever, right? Septic. JVD depends on where we are. In initial states, they'll be low, and as we deal with it, it depends on where we are, right? And it's always relationship when you're seeing hemodynamics here. They're always talking in relationship to medications, right? So let's talk about the meds, right? So why would a patient on septic shock get dobutamine? Well, I mean, if we've increased the volume so much, right, that, you know, a normal person doesn't have 4 to 6 liters hanging on them, right? So that's a big volume. If you have all this volume in the heart, it's going to really stress out that heart. So therefore, that's why you would use dobutamine. Also, if you have hemodynamics, like cardiac output is decreased and wedge pressures are high and all these type of things, well, we need to perfuse the heart, perfuse the organs. Neo, right, depending on the stage, right? So remember, the problem is in the vasculature. So therefore, they'll strictly need alpha medications for that. Vasodilators, not most likely. You only see vasodilators, milrinone, nitrate with cardiogenic shock, not with septic shock, because we don't mess around with the alpha, right? The alpha's already been screwed up, so we don't want to screw around with that. So then beta and alpha, a little bit of beta. Okay, so we said that there's one heart, so beta, and a little bit of alpha. Right? Well, level-fed is one of those medications. So level-fed, leave them dead. So what would happen is we put this up so we can gently pump the volume, and then we can gently squeeze that patient. Perfect situation. And that's why you see level-fed norepinephrine in sepsis bundles, because it's a perfect medication for a septic patient. Now, dopamine is a 3-tier one, where we said that it starts off beta, then it becomes beta and alpha. We said 0 to 5 is beta, 5 to 10 is alpha and beta, and then greater than 10 to 20 is the max, depending. So did you see 25? It's strictly alpha, right? So it's only going to be squeezing at that point. So if you have a dopamine drip at, you know, 12, I mean, that patient is just going to be straight up alpha. And so, would you have dopamine at 12 and neo at 80? No, right? These are both alphas. They're doing the same thing, right? So, and that's that. That's sepsis in a nutshell. Any questions about this? I'm not seeing you because I can't really see who's sleeping and who's not. All right, let's move on then. All right, so let's get into it. So let's so we're going to talk about this guy right here, and this works really well for sepsis patients, right? Because it's pretty much the whole show, right? So, but we're going to use we're going to walk through with the SHAM-LD on the case study, and that's what we'll start to do. So let's start to move it up. So take a piece of paper, right? So set it up, right? And set up your paper, and let's kind of walk through the case study. When you're doing case studies, this is a good exercise to do for case studies because it helps you understand and conceptualize this on a piece of paper. And so I'll set up my sheet, and it's a septic patient. So I'm definitely going to do my BMP and CBC, right? So I'm definitely going to do I'll set up my this, definitely going to do this. Right? So I'll set that up right away because I know sepsis is going to be that, right? So, and let's see how this patient evolves for us, and let's kind of go through it. All right, so an overview, you can read this yourself. It's
sepsis is a systemic inflammatory.
Yeah, and that's a big case. So let's kind of walk through it really quick. So sepsis is an inflammatory response, right? So we talked about that, right? So we said, this to heart to inflammatory response, the inflammation is vascularized, right? So to document suspected infection, right? So we have CBC, we have this, right? And we're going to go down to the differential. We said that with the WBC, if you have 16,000, what was it before? Right? So that's a big key. And also, what's the differential down here? So severe sepsis defined, complicated by organ dysfunction, right? So as it becomes hypovolemic, they become pre-renal, they become intrarenal. All right, so diagnosed, thank you for that. Mortality rate is really high. Septic shock is the presence of sepsis with hypotension. And we just kind of talked about that. So you have hypotension despite adequate fluid resuscitation. So that's fill the pump before we squeeze, right? Before we alpha. All right, so sepsis can occur at all ages, so it doesn't matter, right? So it goes back to this sheet, right? So this doesn't really matter at all. So you're gonna have anybody there, right? So let's move into it. So we saw some things, right? We saw hypotension, right? So that's very specific, right? And let's go. So identify relevant assessment data, some objectives, compare contrast stages, evaluate results, prioritize nursing care, and delegate and describe it to professionals. All right, let's move. All right. So as we're moving on a SHAM-LD, right? So we have, we have S, H, A, M, L, D. All right, so we have a 58-year-old female, so 58, right? So female. History of type 1. Okay, so type 1, that's acute, right? So I'm going to move this right over here, and I'll do this box here. That makes type 1. So I already know that. So the next thing I want to know is what's the last blood sugar, right? So, I mean, that would be acute. This will complicate sepsis, right? Because now all of a sudden you have bugs in the vasculature, right? And you have sugar issues, right? So since age 8, so they're definitely aware of how to manage things. Hyperlipidemia, okay, so I got CAD up in the history. Renal insufficiency, okay, well, what kind? So I have chronic kidney disease, so I don't know what kind, so I would have to go down to their BUN and creatinine. and then go down to the GFR to figure out what kind of stage they're at. And we said that 1-5 is barely alive is stage 5, and she would be a dialysis patient if I saw that. 60 is the cutoff, and then we start to move on. All right, so IV ovarian cancer 4 months ago. Okay, so cancer. Okay, so CBC. Right? So CBC, immunosuppression, platelets, right? White count. All right, so let's keep going. Surgical management at the time we call total hysterectomy, so she lost her guts, right? So by oophorectomies, menectomies, and lymph node biopsies, okay? So immunosuppressed cancer, right? So cancer moves through the lymph nodes. We talked about that with renal disease, right? So 2 weeks after surgery, 2 weeks, okay? So look at aggressive combination of chemo was started. Husband brings it to the ED, okay? With shaking, chills, and fever, all right? So hot, so symptoms 3. Hot, chills, right? But we all know that. We know what fever is, and that's why we have fever protocols, right? Last chemotherapy 2 weeks ago, states she's very weak. What does that mean? Barely able to hold her head up. Well, that's pretty bad. Vital signs obtained by you, the triage nurse. All right, we'll talk about that tomorrow. All right, blood flow. All right, so let's so 96 and 72. So what's the mean arterial pressure? So 96, 72. 96, 72. Well, that's low, right? It's less than 100, so thanks for that. So hypotensive. So if we're looking at this patient and we're looking at the heart, we're looking at the vasculature, it's already starting to have problems. Volume is going down. So these vitals would go right here in the assessment area. Heart rate's 120. So this is actually lower than what I thought it would be. So it's actually, it's probably like 80s, 80s and 60s, 80s and 40s. Because this heart rate is most patients do wish, right? So meds, oxygenation, stress, trauma, and so on. Respiratory rate 26, okay, so that's the boat coming. We talked about respiratory rate from 25 to 30, right? So respiratory rates, the boat is coming. Hey, there's a boat right here, right? So saturation's at 92. I'm concerned more on, our PaO2 and what we talked about with the SvO2, venous oxygen, right? That's important to know because venous oxygen, when it goes to the fingers and toes, is what comes back. So normal pulse ox is 96 to 100. That's a normal. You or I sitting in 96 to 100, right? But if we're in respiratory distress, we would do a PaO2. So PaO2 should be 80 to 100. And that's what we do for ABGs. Well, once it goes, and that's arterial, and then it goes to the fingers and toes, and it comes back as the SvO2. So we said the V goes to the sideways, becomes a 7. So just remember, you want that greater than 70. If it is less than 70, that patient's, the fingers and toes are saying, give me oxygen, give me oxygen, give me oxygen, which means that their cells starved. All right, so tympanic, right, is more accurate than a buccal, right? So 102, and that patient is definitely septic. All right. So temperature, right? Temperature, hypotension. Right. Not so much this. Well, this is hypotension with, compensation. All right, so immediately assign pH to the ED bed based on the knowledge of patient's high risk sepsis for related to what? All right, so let's see on them letters. All right, SVR is up because body's not aware of the volume. Yes. So the question was, is SVR up because body's not aware there's a volume issue? The hypovolemic SVR is up. However, septic SVR is down. Would you give colloids for that patient? On a hypovolemic patient, no, right? So hypovolemic, you give them blood, you give them fluids, you treat the underlying cause. Where colloids only show up in septic patients. Generally, when we're trying to move fluids and different things. No pressors, right? Always fill the pump before you squeeze. Hemodynamics depend on early shock versus late shock. Hemodynamics come into play when you're in late shock. right? So we see the patient in early shock. Okay, so we see the patient in early shock, you know, fever, chills, the data, right? We're managing the patient with hemodynamics. Once we have hemodynamics in the question, sepsis hat on, management. All right, so whether you're going to give fluids, pressors, or what have you. All right, yes. All right, so I'll cut those questions out. That's kind of why I do this, right? So just a number. I have to scroll through the whole video. All right, so yeah, immunosuppression. That makes sense because, you know, immunocompromised means risk for infection. All right, so next. All right. You conduct a focused assessment. Select the priority evaluations that should be part of this document. Focused assessment. Okay. All right, so let's talk about focused assessments, right? So, right, we're not looking for things, right? So, I mean, we're getting a focused assessment of the problem that's going on, okay? So if I come in, you know, with a headache, you know, I'm not going to do cap refill. You come in with broken foot, I don't care what's up here on my capillary field, but I might look at the foot, right? Focused assessment. This will come into tomorrow when we talk about trauma, right? Because focused assessments are not looking for a potential problem, looking for an actual problem, what's going on with the person. So when we're looking at things, so we have a patient here who's septic, okay? So you have a situation going on with this patient, right? So, and we're trying to assess that situation of the patient. So let's take them one at a time, and what I want you to do is just do true or false, okay? And then we're going to kind of go from this. And then when we're looking at SHAM-LD, we have the person, right, under the A, and this is when we're going to do this stuff, right? So, all right, so the first one, so you'll either say true or false, or T or F, right? All right, so first one, bowel sounds. What do we got? All right, so bowel sounds, sign of what? Sign of perfusion, right? So sign of shunting. What's the first to go, right? So if you found out, yeah, your gut's to go, right? So if you think about this, right? So here you are, you're running from a bear, right? So if you're running from the bear, it goes to the core, to the heart and the lungs, right? So the risk is the butt and the gut go to sleep, right? So a patient who's septic, and this patient is hypoperfused, right? We saw that before, right? We saw that their vital signs, hello, getting there. Their vital signs are 96 and 72, right? That's pretty acute. So, I mean, and you have heart rate right here. So we have an issue. We have shunting going on. How do I know it, right? Do I have hemodynamics? No, I don't, right? So I'm doing a focused assessment. And what I would I expect hyperactive or hypoactive? Okay. So that's the thing you have to think about. Would I expect hyperactive? No, I wouldn't expect hyperactive. I would expect hypoactive. That would become very indicative that, wait a second here, low blood pressure, high heart rate, patient's starting to shunt right now. What looks like sepsis, sounds like sepsis, smells like sepsis, is sepsis, right? So good baseline. All right, so the patient bowel becomes ischemic, right? They suddenly start to pass melanous stools. So if they're passing melanous stools, and I never assessed bowel sounds, and paralytic ileus, right? So incarcerated bowels, all those type of things. So yeah, assessment, focused assessment, baseline, figure out what's going on. So this is actually true. All right, capillary blood glucose, true or false? Yep, so that is true, right? Because we said that she's a type 1. We still don't know a GFR or anything like that. So down here, I'd expect sliding scale of some sort. complicated. So important to know baseline, type 1 especially. All right. C, true, false. Yeah, so now it starts to make a little bit more sense because capillary refill, right? Yeah, definitely, because, that's shock, right? So we're looking at the patient's perfusion, right? Are they becoming hypoperfused? Right now, I just have blood pressure, heart rate, and a fever, right? And some history. But I don't really have sepsis yet. So I haven't done blood cultures. I don't know. I think it's sepsis. So, yeah. So let me see what the perfusion is like. Okay. Date of last bowel movement, true, false. All right. When was your last bowel movement? Holy crap. Darn, bowel movement. Right. This is something that's drilled in your heads, right? So, you have a septic patient here. Do you care when they last moved the bowels? Right? So think about this. Okay. You have capillary refill. You have less than 3 seconds. Important? Yes. Okay. You have a blood sugar, right? It's 300. Important? Yes. You have hypoactive absent bowel sounds. Important? Yes. They haven't crapped in 2 days. Important? Right. They crapped yesterday. Important? They crapped today. Right? I mean, what are you looking for? Like, when are you looking at for? Like, what's the time frame that you need to know? Nobody knows, right? Because, yeah, right, actual problem or potential problem. If you have absent bowel sounds, actual problem, potential problem. If the person had a BM yesterday, 2 days ago, 5 days ago, is it sepsis? Is that why? No. It's normal, right? I mean, we don't really, I'm not going to explore that. It's not data I need. I'm not going to be like, hey, doc, it's good. The patient hasn't pooped in 2 days. Well, I wasn't looking for 2 days. I'm looking for 3 days. Only call me when it's 3 days, right? Like, I don't even know. Like, when are we really worried about it? Right? Because it's kind of one of these things that nursing 1, nursing 2, you report last BM. I want to know last BM. It's like this old school type of thing of motility, right? Where it's only important on a post-op patient if they're positive flatus because of shunting, right? And it's about bowel sounds, right? If you have positive bowel sounds, you should have intake, right, and output. Well, not important. All right, so E, true or false? Yeah, what kind of pathogens? What do you think? Yep, right, precautions, right? So it goes back to this, right? Been around anybody sick? We talk about that now, right? With COVID, all that type of stuff, right? So the whole thing of what's going on with the patients in COVID is that, even to get screened, you're going to make sure that you've been around, you've been, non-quarantine, all these type of factors, in order to even get a test. Because it doesn't you just don't test people just to test people. Unless you're the governor and the governor's brother, you can get them whenever you want to get them. But, us normal people, right? They're not just testing everybody just to test people, right? There has to be a criteria. I was doing some research on it. There is a criteria out. It was just presented. I'll bring it up tomorrow, if I remember. All right, so yeah, you've been around any sick people. That's important. Well, you're immunocompromised. That's important, right? So that's all. Okay, so that's okay. Next, mental status assessment. True, false. Of course, right? We want to know the mental status, right? Disorientation. That's why in the assessment area, A and O times 3. I'd want to know that right away in assessment, right? So when you're rolling, you go from your statistics to your history. You ended with chronic kidney disease. I don't know what stage because I didn't look at it. But my assessment's as follows, right? My assessment's as follows: the patient is alert and oriented times 3. I'd want to know that right away. Patient is disoriented times 2. I'd want to know that, right? Patient thinks they're Superman. I'd want to know that. You know? All right. G. Yeah, it doesn't make sense, right? What are you looking for? Right. So that's the thing. Is it a muscle thing? Right? So sepsis, is it a muscle thing? Well, they do get weak. Yeah, but what's weak? Right? So it's not a muscle thing. It's not like Guillain-Barré. Right? That's, you'd want to know, right? A stroke, want to know. Right? Because that's muscle, muscle, muscle. Myasthenia gravis, right? So all these things that are muscle related, but this is not a muscle related thing. Oh, but Kevin, it's sepsis and they're weak. That doesn't mean muscle inequality, right? Equality is bilateral. This is not an ipsilateral type of thing. A patient with a DVT, those type of things, vasculature, surgeries and stuff. But even then, it's not so much muscle strength. It would be other bilateral pulses, those type of things. All right. Next thing is H. Yeah, that's a no-brainer, right? I mean, how do you know they're filling up? How do you know is it a pulmonary issue? We don't know. Okay. Next thing is I. Yeah, I mean, this is the same as, let's do, can you look up? Can you look down? Can you look right? Can you look left? All these type of things, right? So, I mean, is it important? Is it necessary? Hold on, let me, palpate you, right? I mean, what is this, a head-to-toe nursing 1 assessment, right? I mean, this doesn't make sense. You're looking for something. And hepatomegaly, like a swollen liver? Oh, but Kevin, I read that in sepsis. Come back, right? All right. Pupil reaction. All right. Well, your first question with pupils, right? Your first question: is this trauma? Or is this not? Is this head injury? Is this not? No. Okay. So pupils are for head injury, trauma, acute situations, right? Not for septic patients, right? Like, think about it. Patient has a fever, and they're hypotensive and all these type of things. Hold on, let me look at your pupils really quick. What are you doing? Why are you looking at my pupils, right? Well, there might be something. You're type 1 diabetic. No. Focus assessment has nothing to do with it, right? I mean, it doesn't make sense to do a pupil assessment. Oh, but Kevin, what if they're not on vasopressin? The patient's in the emergency department right now, right? That's a focused assessment. Patient's neurological changes, pupillary assessment, right? Patient's change in GCS, pupillary assessment. Patient has a head trauma, pupillary assessment. So, all right. So next one is K. Yeah, I'm getting a blood glucose. What did you get, and what was it? Right? What am I looking for? I don't know. But the reality is, if they told me they were taking the MPH, or they were taking, whatever the regular insulin, whatever they were doing, right? That would be important because I know where they're going to. Right? So, L. Yeah, a little split on this one. Okay, so let's talk about it, right? A septic patient. Right? Risk for shunting or not shunting? Shunting. Okay, so the risk for shunting, their septic patient, So the question is about the septic and the risk for shunting, and they just had 12 White Castle burgers. I mean, that would be important to know, right? Because I'm probably going to end up throwing an NG tube in them on OG tube. Patient might become vented. That might also be an issue, right? So a patient who is septic is going to go very quickly down it. So I want to know, what they ate today, if they ate anything. All right, so M. Yeah, definitely urine output. Right? All right, next one. All right, so you find pH oriented to person, place, and time. Okay, so SH, right? Okay. A, so alert and oriented, right? But restless, okay? And apprehension. Restless, we always said, is acute, right? Restless is acute because that's the patient you see first. So breath sounds reveal crackles, right? So at the lung bases, skin is warm, flushed, right? So vasodilated, capillary refill, okay? Hypoperfusion, right? Abdomen is soft, non-tender, hypoactive. Good thing we looked at that. She cannot remember the last time she voided. Okay, that's also important because hypoperfusion. Last meal was lunch 6 hours ago. She took 6 units of regular insulin to cover her perennial blood glucose of 3. That's high, so 306, right? She ate half of the turkey sandwich in a glass of cream. Blah, blah, blah. Capillary blood glucose currently is 348. States she was home. Her son was home from college, was diagnosed with bronchitis. Okay, important to know, right? Because infectious, patient is immunocompromised. So let's move on. Okay, so we'll take each one again. True, false, true, false, true, false. Which findings in the pH focused history and physical put her at high risk for sepsis? A, true, false. B, true, false. Yeah. So we know that, right? Chemotherapy, right? So immunocompromised, right? So the white count, neutropenic precautions. We say that, that's why we say high is always acute, right? So high is acute because that's infection now. Low, don't bring a flower stat, right? You put a mask on. Protection, neutropenic precautions, still important, but it's higher Maslow. Most of the time in NCLEX, you have neutropenic precautions. You're going to be teaching family about this, or you're going to prevent things. So with assessment, delegation, management of care, the higher Maslow stuff as leadership is that when you see this stuff going on, you stop it from happening because it's a safety thing. Now, neutropenic precautions are highly tested on because it can put the patient at risk. All right, so history of diabetes, mellitus, definitely important, right? Because sugar loves, bugs love sugar, right? Men in Black, right? So hemoglobin A1C is also important. So we said that hemoglobin A1C, 3 to 5, is you or I, 5 to 7, almost to heaven, which means that's problems, right? They're not really, that's kind of where we want a diabetic, but, if they're type 1 or type 2, they're going to be in that 5 to 7. That means they're managing their sugars greater than 7, going to heaven, that's bad, and 10 or 12 also. They're definitely not managing that sugar. All right, so C, hyperlipidemia. Yeah. Right. What does that mean? Right. I mean, high lipids. But they have cardiovascular disease, and if they have cardiovascular disease, then their perfusion is going to be less to the heart. And no, wait. What's going to kill a patient now? Hey, doc, they got hyperlipidemia. No, it doesn't mix. It's not. If hyperlipidemia with XYZ, but even then, it's very big. All right. Delayed capillary refill. Right. Okay. So history and physical put her at high risk for sepsis. This is just a symptom of what's going on, right? Just because she has a decreased delayed capillary refill means that it doesn't put her at risk for sepsis. It means that we still need to treat it, so we would treat it. So it doesn't mean that's a risk. All right, so E, true, false. Yeah, that's true, obviously, right? So there's the vector, right? So, I mean, cough, neutropenic precaution. Should have had a mask on and different things like that. Hypoactive bowel sounds. Yeah, same thing, false, right? I mean, that's the result of, it doesn't mean it is the cause of, right? So it's a result of, it's a reaction. Right? So hypoglycemia. Right. So now you're taking the content and moving into it, saying that, well, Kevin, well, what are you looking for? Like, what do you mean? So if they have 110 or 120, is that going to complicate the sepsis? Well, it could. I don't know. Is that the stress response? Right? So with that, it's the same as a hypoactive bowel sounds. We talked about this issue, right? The management of the diabetes. But the hypoglycemic, what do you mean hypoglycemia? Right? So, I mean, the 300, I mean, you're giving insulin, right? So, plus the sugars, are the sugars real? Or are they the stress response, right? Are they related to the corticosteroids? And there's a lot of data about that. Like, do you give them? Do you not give them? That's all over the place. So if you see questions like that, it tends to be, that's a gray area, and nobody really has. There's a lot of studies done on that, like what you'll do with that. So this is actually false. Hyperventilation. Nope. Yep. And that makes sense, right? Hyperventilation, I mean, that's a result of, right? And then soft, non-tender abdomen. Yep, false. All right, so next thing, moving on. All right, so which findings reflect compensatory stage? So compensatory stage is the body's reaction to the sepsis. So, what's going on with the body. And, all right, so let's go first one first. All right, A. Yeah, that's easy, right? Because we said that skin will vasodilate, all that stuff. So you see hypoperfusion. You also see this, right, when we talked about autonomic dysreflexia, right? When autonomic dysreflexia, the response of that and that person being up here, they flushed up here, right? So B. Yeah, that's most patients do wish, right? So medication, this is in relationship to this, it's infection. C. What the hell does that mean, right? I mean, soft, non-tender. When you're thinking of abdomen, right? Abdomen is trauma. Okay, so trauma is acute, right? So if you have a hot belly, that's acute. If you have peritonitis, that's acute. If you have a ruptured aneurysm, that's acute. So if you have rebound tenderness, pancreatitis, appendicitis, that's acute. Right? So that's episodic. Sepsis is not episodic, it's hemodynamic. Right? Delayed capillary refill. Right, those are your sight readers out there. Right? Looks like sepsis, sounds like sepsis. Do you think that capillary refill delayed is compensatory? Do you think that it's necessary? Or do you think it's the result of something that's wrong? Right? So, for example, if you had a patient who's septic and they're tachycardic, skin's warm and flushed, right? And they had normal capillary refill, right? So would you hand vasopressors on that patient? Right? Would you fill that pump? I'm not sure. I need more data. So if you have delayed capillary refill, is the body's natural mechanism to slow diffusion? No. So that's not a good thing. That's not compensatory. That's means it's not working. Whatever's going on, the patient's getting worse. Okay. So remember, the heart rate increasing is to help the cardiac output. Body's natural mechanism. It's kind of what we talked about when a patient is bradycardic, right? So if a patient is bradycardic, the body's mechanism isn't to slow it, unless they're an athlete, right? Because they've conditioned their bodies to be, in shape. But the heart rate is always compensatory, always goes up. And it's only because we cause that problem, right? Beta blockers, digoxin, calcium glycosides. So it should never really go down. So the same thing with capillary refill. It shouldn't be delayed. I mean, that's not the natural mechanism. That means that there's a problem going on. All right. Hyperventilation. Yeah, it's an oxygenation problem, right? So hyperventilating, breathing to increase oxygenation. That's a natural mechanism. All right, and that's why we said the boat coming is, respirations are all over the place at the low levels, right? So I had a student said to me, it's like, well, your numbers are all wrong, and what I see in the book and all those type of things. I'm like, well, you're missing the trees in the forest, by thinking that way. Listen, when I do the research, so when I see it, what I see is trends, and I teach application. If you had a patient that's tapping away at 25 respirations in a bed, that's wrong. The patient shouldn't be that high. However, that 20, it's like I said, the UAP, 20, 18, I'm 17, it's like, it's so subjective, objective, right? So in a question though, they're not going to play around 20, 18 unless it's normal. But you see 26, you see 28, 29, 30. 30 is restless, distress, and then we talked about that before with failure. All right, so hyperventilation, hypoactive bowel sounds. Yeah. Yep, true. Yep, that's a good thing, right? You would start to listen. You're starting to run from a beer, right? So, rest and digest. Like, let's not worry about that hamburger, what you ate, that turkey sandwich you ate earlier. Let's start to deal with that later, and let's pump the heart out and stuff like that. So it's a compensatory mechanism. All right, G. Right. So lethargy, right? I mean, once again, right? Is that a good thing? Oh, Kevin, if they're resting, this and the other, but lethargy, I mean, that's kind of the result of, lack of perfusion, right? So next thing is restlessness. Right. I would consider this true or false. I'm not 100% positive on this, but in the current situation of this patient, if you are restless, right, it's kind of like if you have a splinter in your foot, do you just keep on walking around? Do you know it? Right. So that pain response does that make you pay attention to what's going on with you? Right? Will you continually walk all day long on that splinter, or will you address it? All right. So if a patient is restless and hypoxic, those things. So you split your hairs a little bit with this one. This one I'm a little bit questionable on it because it's, it would be an indicator to you started becoming more anxious or restless. you're more likely to seek help. So it is a stress response. A stress response would solicit a treatment, something to do something, right? To sense of urgency to it. So I would consider that true. All right. So increase urine output. No, decrease urinary output. Compensatory or problematic. At this stage, we're moving towards hypoperfusion, right? So pre-renal failure. And is pre-renal compensatory, or is it the result of? It's a result of hypoperfusion, dehydration that hasn't been corrected. So now we're in a acute situation. All right, next thing. When you suspect pH may be septic, you consider the pathophysiology, clinical manifestations of shock, unrelated physiological process. Occurring in septic shock. Shock is related to a blood flow. Right. Letters. Yeah, decreased amount of blood flow. All right, so let's match these. Compensatory, progressive, and refractory. I would just write C, P, R, and then I would just do A, B, C, and then just draw your things of what you think it would be.
Come on, shit.
All right, so refractory is, I would say, you know, with this stage, you always want to look at what's the worst, right? So it's always like the first, the last, and then you figure out the middle, right? So whenever you have these type of things, it's always, okay, well, what would be first, what would be last? Once you get that, then you go to the other thing. So ultimately, the multi-organ failure, that's definitely the last, right? So that's problematic. And then you have the compensatory, active neurohormonal mechanism increasing consequences, right? So maintains, to maintain homeostasis, compensatory. All right. Talk about that. All right, so now compensatory, progressive, refractory. Actually, I think where we at? All right, so let's talk about whether it's compensatory, progressive, or refractory. All right, so compensatory. Right? Compensatory means heart rate increases. Compensatory. Progressive, right, means that no longer compensation. Right? Heart rate's increasing, blood pressure is now decreasing, patient is becoming ischemic, those type of things. Refractory, point of no return. Right? So call the doctor, call the family, and let's start to go. All right, so let's go. You're either going to say CP or R, and let's start. All right, so mottled cyanotic skin. Yeah, I'd call the doctor. I would call the family. They start seeing the patient modeling. That's a big acute thing, right? I mean, it's usually our first things of when a patient is agonal breathing or apneic or those type of things. They are. We look for those signs. Once they start to model, right? That's a bluish color. That means that it's happening, right? It's within minutes that this person is just going to die. So we would definitely call and that's refractory. Right? Increased heart rate, narrowed pulse pressure. Yep, compensatory, right? So, right, it's compensating, right? So we know that. Okay. Decreased BP and bradycardia. Right, it's progressing, right? So that's progressive. Venerea. All right, so venerea, right? No urine, right? So is that, do you call the doctor about that? They call the family in because the patient's going to die, or is it progressive? It's progressive. All right, that's the same. Delirium. Yeah, progressive, right? Moist crackles. Pale, cool skin. That's refractory. That's bad. Hot to cold, bad. And we said that goes back to the shunting, right? So at that stage, the brain is saying, this is number one, don't care, right? About the skin and everything else. Oliguria. Okay, they're probably saying that this is progressive, refractory. I would say, okay. Yeah, okay. I might have made a mistake with that. Maybe I wasn't looking at it. Sorry. Decrease. This is a repeat. By severe hypoxemia with respiratory failure. That would actually be progressing, right? So respiratory failure would relate to that patient being vented. Okay, so patient is admitted with sepsis. Patient has distress. Okay, patient is restless. So they'll compensatory mechanisms, right? Then distress becomes failure. So therefore sepsis has now progressed. Patient is failure, they're put on a ventilator. Okay, at that stage of ventilation, then we need more data, right? So it's not like ARTS, despite the FiO2 and so on and so forth. So mottled cyanotic, that's a repeat, and hyperventilation. So I don't know, I must have made a mistake on this slide. All right, next. All right, so the ED physician reviews your data collection, examines the pH. Following orders are written. Stat, BMP. Okay, so that would make sense, right? So we have a stat BMP. We have a CBC probably, yep, and liver function tests. All right. A lactate level. Right, so lactate, is important. Blood cultures ×2, right? That's important. Urinalysis, uroseptic, culture sensitivity, sputum culture, ABGs, okay, and PTINR, coags, right? Because clotting cascade, and a fibrin split products. All right, so products. Sorry. So this is fibrinogen, fibrin. We talked about that with the clotting cascade. So when I always think of like fibrinogen or fibrin, you know, think of it like this, right? Platelets plug. We talked about that. The circulatory, right? They solve the problem. So platelets plug, right? Fibrin, fibrous, is like glue. And that's kind of the difference, right? So as platelets are circulatory, clotting factors form the clot, and then fibrinogen is the glue that keeps it all together. All right. And that's why you do a fibrinogen level, those sort of things. All right, so chest x-ray, no kidding. O2, yep, PRN, keeps sats greater than 92. Cephalotrioxone, right, 2 grams every 24. Bolus, okay, so increased bolus. Increased urinary catheter for pre-renal, and prepare for a central line for CVP monitoring. All right, so let's move. What is most important to complete before giving cephalotrioxone? Yep, D. D makes sense. Right, hydrate, right? So with 1 liter or no, it's not a bad thing. So this is what do you do first, right? Out of all these orders, right? So that's kind of basically what this is. Yeah, this is what you do first, and then you know, then you would do this, then airway, this, ABCs, okay, and then document at the end. All right, let's take them one at a time first. All right, so what's the first one? Yeah, definitely low, despite, then the second one, F, correct. And then the last one. Yeah. All right, so lactate acid. All right, so now this number is, it all depends on whether they're doing microdeciliters versus, so, and that's where it gets a little bit difficult with doing like sheets and different things like that, because sometimes people refer to it as like here or an ml or vice versa. All right, and that's kind of where that number gets all over the place as far as what you see. And we saw on the sepsis protocol, it's different, the number, right? So which means that this case study, they're focusing on that way that they're going to say it, where this other studies are saying focusing on it this way, which means that it's gray in the way that they're going to talk about it as far as numbers are concerned. So what it means that if you ever tested on it, lactate acid, that you would need to know. Okay, that's what you need to know, is that with the lactic acid, that is sepsis. Okay, it's like a D diamond. Don't need to know the numbers because the numbers are kind of all over the place. It's the same thing when you talk about myoglobin and CKs and stuff like that. All right. NCLEX tends to stay away from those kind of numbers and stuff. All right, let's take a quick break and come right back. Take 5. All right, so after 1 hour after receiving IV fluids, IV antibiotics, pH blood pressure continues to trend downward, right? So we know that the issue is that the problem is in the SBR. So they're no longer compensating, so progressing. So SBR is starting to decrease. Continuous trend with CVP reading is 6. Okay, so third bolus of normal saline is administered, no hemodynamic improvement. ED physician orders the following. Give level-fed infusion at titrate to mean, arterial pressure greater than 65. At this stage, perfusion in the brain, we're already past that, right? So now we're just trying to protect the organs and get everything set. Famotidine, right? So H2 blockers, right? So if the brain is no longer being perfused and we're just trying to maintain that, they have definitely shunted at this stage. So H2 blockers because the gut rests, right? Because risk is ischemic. And regular insulin because now we're in the stress response. All right, so I guess this is asking what is the cc's per hour, and because we don't have time, we're just going to say it's 120. All right. IV famotidine multi-dose vial at 10 milligrams per ml. The order dose is 20, and let's do this math. All right, you recognize the hyperactivity caused by the alcohol withdrawal. It's a different patient, I think. Increasing naturally each complication, pancreatitis. This is the wrong patient. Crap. Let me see. This is the right patient. I'm back to pH. So B, right? So B is the ideal situation. This is a tricky question in the sense that we know it's not 2, right? So we say that CVP, right? So we start from cardiac output and we go 4 to 8. So then we have this, right? So then we have, okay, well, that's too low, right? Because 0 to 8 is definitely low. Right? This is just enough, right? So, and that's normal ranges generally. Right? And this is too much, and this is too much. So B is the correct answer. There's some argument for 9, being better, but if you're looking just at numbers, these are hemodynamic numbers. So it's a little bit different. What was it before? What was it now? Right? If they've gotten 3 liters of fluid, would I give another fluid bolus based on this? Probably. Because I'd want to bump them up. Would I give another fluid bolus based on this? No, which means I would go to the next treatment, right? And then hopefully that the kidneys are so focusing. So this is the correct answer. However, this could be correct too, because sometimes you want them a little bit wet. Is the issue is that because volume's a problem. pH condition is medically complex. No kidding. She's critically ill. WBC count is 21,000. Gram positives. She's more confused than obtunded, so getting worse. SAT's 85, so she's in failure. You're not a breather, consequently she's intubated. And G2 place, right, gut rest. Enteral feeding, so we start to feed the gut because of cellular death, right? So you just because they're shunted, you're not, we're still going to do TPN and all that type of stuff to get things moving because all those cells that have broken down need repair. Tolerant if using in plan of care, you collaborate the respiratory therapy to maintain endotracheal cuff pressures between blank and blank. Yep, I've got 420, right? 20 to 25. That's up range, C to D. All right, understand preventing ventilator-associated pneumonia. Right, so that's the VAP tube. So this person will have that ET tube in. And then we said that that ET tube will also have a VAP tube, ventilator-acquired associated pneumonia, right? Because that's going to suck all the mucus above the cuff, right? And all right, so let's interventions. Let's take them one at a time. All right, A, true, false. Yeah, we'd want that positioning, right? 30, 45, right? Generally, vented patients are not high followers, right? B. So yeah, we're going to shut down that OG tube, the NG tube, feedings, and all those type of things, because we're moving the patient around, and especially if it's I forget what they put in the NG tube or not. Movement, right? Movement risk for aspirations. Right. C. Yeah. D. Right. So gut migration. We talked about that. E. Right. The mouth is dirty. Some people more than others. Right, so that makes sense. F. G. H. But that's basically saying this is a VAP tube. That's what I was just talking about here. I. So let's look at I first. Does everybody know I? Right, so if you're not sure, right? Right. So if you think, does everybody know this ventilator circuit thing? Right. What's the policy? It's false. Right. It should be absolute. Right. Based on policy. Right. Healthcare provider determines the need for Medrol. How this drug will help his wife. All right, so this is a newer case study. So steroids, let's talk about this. This is the correct answer, right? It's weird because you don't like think of steroids and blood pressure, right? What they find is that the study states that patients with steroids are only usually indicated for patients who can't maintain their blood pressure despite fluid resuscitation. Now, we really haven't talked about that, right? This is a newer study because the standard is generally steroids, right? What they find is that the new evidence base is that this patient who's unable to maintain their blood pressure, this steroid will help with that, and that's why. But we don't cover that because it's not current, and NCLEX is going to test you on steroids generally, and that's why. All right, so you vigilantly monitor pH, vital signs, capillary blood glucose readings, urine output, gradually organ function improves, pH is weaned from the ventilator and a vasopressor grip. You're currently aware she's very fortunate to recover from severe sepsis. All right. Save today. Chalk this one up for save. All right. Was it helpful? Yeah, so, I mean, you know, case studies tend to, pull everything together. It's a good thing, and also picks up the pieces. It also helps, especially with content. So it's always, you have to know some of the content in order to answer a case study, and that's kind of what it does isolating what the concerns are. All right, so as we're going to start to talk, so that's sepsis. So sepsis is a hemodynamic process, and understanding of hemodynamics. So when you're looking at this patient, generally when I do case studies, I tend to do sham-only, and I just kind of walk through it, and just to kind of keep myself in, as far as like what content I might be missing, because what it does is focuses on what you need to know, right? And then because right now it's like you want to study everything, or you're watching videos and they're talking about way beyond what you need. Trust me, what we talk about is enough. You don't need to go any deeper than what we're going. And we go pretty deep with the content, so it gets kind of all over the place when you start to look at videos, because you have to weed through those videos to figure out what they are. So tomorrow we're going to talk about trauma and the main concern with trauma. And we take this patient right now, and we kind of look at sepsis with this patient. So and now thinking about it, you kind of think about this patient. So what was her presentation? Her presentation was she was a chemo patient, right? So she was in contact with, so she was just basically walking around, but she was immunocompromised, so she needed teaching and different things like that. So because her son came home and he had bronchitis. Well, they were aware he had bronchitis. However, nothing was done about the video will be posted. So nothing was done about it. Right? So there was no teaching done. So post teaching would be important on this patient. So some symptoms 3 for this patient. The patient had a fever. The patient was restless and hypotensive, right? Low blood pressure, right? They also were hypoglycemic, but I mean, the type 1 diabetic, so not really what we'd be looking for. So are all shock patients febrile, or is it just sepsis? Just sepsis. Yeah, sepsis. Anaphylaxis, there's some arguments about the type of anaphylaxis the patient has. Like, think obesity patients get hot, those type of things. But most likely it's sepsis, and, it won't be anaphylaxis, because sepsis is a hemodynamic phenomenon, right? It's a process where anaphylaxis is right now. So fever, blood pressure, and increased respiratory rates, all those signs of symptoms, temperature, and so on. So precipitating was her son, right? So had bronchitis, so that was the vector, and obviously no mask. We were preventing the main complication, which was organ failure. This patient didn't get to that stage. This patient actually stayed in the progressive phase, right? Didn't go to the refractory phase. So they're in the compensatory phase. They went to the progressive, and she kind of stopped before the refractory. All right, so we put her on a monitor, which we're monitoring her blood pressure, which was pretty hypotensive on presentation. And then you saw some capillary refills with this patient, because hypoperfusion. Labs, you saw lactic acid, right? So we saw that. We saw a white count. What else did we do? We also did the coags, because preparatory, right? So preparing for a baseline. We looked at an A, B, and G. She was ultimately vented, right? And we also did liver enzymes, because we're looking at multi-organ failure, right, for this patient, baseline for where they're at. We also did a fibrinogen level, fibrin level, and position. We saw patient, semi-followers, not supine. There was a chest X-ray done because of pulmonary insult, IV fluid. So she did receive 3 liters, right? She also was ceftriaxone, that was also given. Nothing else, some medications. And then things that changed with this patient was the acute 3. And she had to be vented, right? So she actually went into failure for this patient. So the doctor had been called. ABG had to be performed. Would sodium be high because of dry? Sodium will be all over the place, but this patient would be mainly hyponatremic, but hypovolemic, hyponatremic. Right? That goes back to osmolarities and stuff like that. Oops, sorry, osmolarities and stuff. So the patient's, sodium will be all over the place. Think about type 1 diabetic, stress, all those factors. So chloride, CO2, all over the place. BUN, creatinine, we never found out her GFR. So, it wasn't really in this case study. Glucose was elevated. She received 10 units, so, stress response. Think of sick day rules. White count was definitely elevated. H&H, we monitor H&H later because of if it becomes refractory, it progresses to refractory, but they start to bleed, DIC, all that type of stuff. Platelets would also mean they're going from the progressive to refractory. They start to eat up all their platelets. Calcium and mag, just for main nutrition and different things. Phosphorus nutrition. AST, ALT, multi-organ failure. What else do we look at? Amylase and lipase we would look at because of the pancreas would start to multi-organ failure. Those are all in the refractory stage. Once one organ goes, the next organ goes, the next organ goes. Coags we continually monitor, mainly because of extrinsic, intrinsic. Triglycerides, she has CAD, so whatever. Enzymes, because all the fluid we're giving. She was hanging on norepinephrine level fed, right? So that was given. No other things, no dobutamine or anything like that. ABG was definitely done. We didn't really see much of it. Mentation was changed, right? Restlessness to obtunded to heart rate was definitely elevated. Lungs, she was very restless. It was high respirations, tachypnic, and then she became obtunded and into failure, ultimately leading into acute renal failure, pre-renal to intrarenal. Temperature is definitely elevated. Pulse was elevated. Respirations went up and then they go down. Blood pressure was down. Mean arterial pressure was down. Pulse oximetry, we were beyond that because we were on the PA. We were continually monitoring CVP, right? We saw that with the fluid levels, and we wanted her 4 to 8. We didn't see a wedge pressure on here because they only put a triple lumen in, didn't do a swan. And pulses, we did see some. We didn't really see pulses on this patient. And you would have done the assessment. She actually ended up walking out, right? So she was discharged and walked away. So with some further teaching about how to prevent sepsis in the future. She obviously went to the ICU, and she didn't have any other further complications that required her to go to another facility. So that's this patient on a conceptual map, on nursing camp. All right. So any questions?